All right, so I guess we'll go ahead and get started. Thank you all for joining me for this guest lecture. I'm glad to be doing this talk for Virginia Wesleyan and for my friend Dr. Myers, who I spent about a year on internship with. I'm thankful that she asked me to do this, but actually kind of surprised given um, some of the stuff she saw me go through on internship and that we went through together, that she would trust me enough to ask me to do this. But all joking aside, I really enjoyed all the time I spent with her there in Augusta at the Medical College of Georgia. And so I thought I'd just start out by giving you all a little bit of background on me and maybe give you an idea of why Dr. Myers asked me to talk about working with children and adolescents. So I got my bachelor's degree from the University of Georgia in 2002, and that was a BS in psychology. I then went on to a master's program in community counseling, which there is a terminal program, meaning not that it kills you, but that you can just stop with the master's and go on to get an LPC. But I decided that I didn't want to do that. I wanted to go on to the doctoral program, and so I went on to the doctoral program in counseling psychology, and I finished that in 2010. The last year of that program, as many of you probably know, is an internship, and that's where I did internship at the Medical College of Georgia with Dr. Myers and three other interns. So I'm the owner of Hampton Valley Psychological Services in Bogart, Georgia. There we primarily see children and adolescents, but I also see some adults. I would say probably 30% of my practice is adults, or 40%, something like that. We do psychotherapy and psychological testing at my office. The picture that you're looking at here, ironically, is me and my wife in China this past summer. So it was about a year ago now that we went there. It was in May, I guess. I think we left May 28th, and so it's, the world has really changed a lot since then. I'm sort of in withdrawal this summer about going on vacation, but hoping that we do get to go somewhere at some point, while also recognizing that safety of us and of other people is the most important thing. So hopefully things will get back to normal here soon, and we'll be able to have class and get back to our lives as normal and see each other in person. So hope everybody's staying safe up there in Virginia. So, what I thought we'd talk a little bit about today, as far as treatment of children and adolescents, is some of the challenges that we face as clinicians in dealing with children that you don't necessarily face with adults, or you may not face them as often. So, certainly, these are only the three that are kind of on the top of my head in terms of the major things that are challenging for me on a daily basis. But there are lots more. I probably could have listed, 100 things that are challenging about dealing with children and adolescents. But these are the three that I felt like were the most salient. And I'm sure if you talk to other psychologists who see children and adolescents, they'd have a different list. These are the three that are most challenging for me. So number one, developmental differences. So we'll go into a little bit of detail about what I mean by that. But I'm sure, given that y'all are mostly juniors and seniors in a clinical psych class, you know what I mean by developmental differences. And here I'm focused primarily on cognitive differences that require some adaptation of therapy that is not really as drastic with adults as it is in children. I find that challenging to do that on a day-to-day and hour-by-hour basis. The next one that we'll talk a little bit about is maltreatment. And in this context, maltreatment of children means abuse or neglect, and we'll be a little bit clearer about how we define those. But lots of times when children are seen in our offices, they are actively being abused or neglected in their homes, and we find out about it. But I would say probably more often what happens is we see children who have been abused or neglected in the past, and that past maltreatment is affecting them in the present. And so we'll talk some more about that and the implications of that. And lastly, we'll talk about medical interventions a little bit. And what I mean by that is when children are medicated for psychiatric conditions. So we'll talk about some common conditions that they take medication to treat. You know, and some of the issues that go along with that, including being careful about safety and making sure that the family is properly educated about the medicine and that they understand the risk. Of course, psychologists in most states don't prescribe psychiatric medications; those are prescribed by medical doctors. But we certainly get a lot of questions about it, given that we generally spend more time with the child in terms of length of time in a 1 hour therapy session than a psychiatrist is going to spend in a med check session, which is usually about 15 minutes and usually done about once every few months. All right, so to start off talking about developmental differences, I wanted to get into the cognitive development of children and adolescents and how that can affect clinical practice. So I remember being an undergrad and thinking, when we were going through some of these developmental chapters, like, why does this matter for what I want to do? I want to do therapy. I thought I might want to do some psychological testing, but I thought I'm not really interested in these stages of cognitive development too much. I don't think it's going to really apply to what I want to do for a living. Turns out I was wrong. It actually applies quite a bit to clinical work, and so I thought I'd talk about that a little bit. Maybe that's one of the reasons why I'm challenged so much by it, is that I didn't pay close enough attention when I was an undergrad. But one of the main things that I think is important to consider is the amount of variability in developmental levels of children and adolescents, and how that requires cognitive flexibility on the part of the therapist to consider how you're asking the questions, how you're structuring the sessions, and how you are getting information that you can use to help the child. And so obviously, younger children have more difficulty understanding complex concepts about themselves and complex questions. They have a lot more difficulty understanding that than older children do, or than adolescents do. But even while adolescents have more insight into their own motivations than younger children, even adolescents still clearly have much less insight about themselves overall than adults. And I put the example on here of breaking their leg by skateboarding off of the roof of the house. So that's one example sometimes that I use when talking to parents about, even though their adolescent seems to understand some adult concepts quite well, that cognitive understanding doesn't necessarily translate into behavioral change or behavior that matches what you would expect from an adult. And one example that I use to help illustrate this point for them is to say, if I was telling you a story about a 15-year-old male, and I said, yeah, he broke his leg yesterday because he did a backflip, off of a Coke machine. You would go, well, I mean, that's what teenage boys do. But if I told you a 55-year-old male broke his leg by doing a backflip off of a Coke machine, you would be like, well, I mean, was he drunk? So there are some of these developmental differences that we take for granted sometimes and don't really think all that much about, but they make a huge amount of difference in a wide variety of clinical settings. So more practically, when we start to think about some of the things that Piaget talked about in his stages of cognitive development, one of the things that I'm sure you probably remember is that Piaget talked about beginning at around age 7, children are able to take the perspective of others, and they use inductive reasoning. And so what that means is that they are taking information into a problem and drawing certain conclusions from it. So they're starting to engage in rational thought a little bit between the ages of about 7 and 11. And then at age 12, it gets more into what he called formal operations, which means that as they start to transition into adolescence, they start to be able to use deductive reasoning also, and to think abstractly about problems. And so any of you who have ever argued with an adolescent probably knows that they can take things really to the extreme and be very, very idealistic, because they think that since they've got these new insights, they need to share them with the world, not recognizing that much of the world, including most adults and their parents, are sort of past that point. I think I can say that pretty openly because I have an 18-year-old daughter. Fortunately, she's past a lot of that now. But when she was 14 or 15 or 16 or 17, or well, even yesterday, sometimes she's hard to reason with. So the broader point being, how does that impact clinical treatment? So what can we use, and what do we know about cognitive development in terms of how to adapt psychotherapy based on these stages of cognitive development? And about specific intellectual abilities, and you'll see, I think, what I'm talking about here in the next couple slides. So I just wanted to give you a pretty basic example of how this might play out in therapy between a 7-year-old in one example and a 17-year-old in another example, where the situation is really the same, but the strategy that you would use and the engagement that you would use with the patient might be a little bit different. So let's say I'm seeing a 7-year-old, and I asked the 7-year-old, "Can you tell me about what happened yesterday when you got into an argument with your little sister?" And he says to me, "Well, Mom got mad and I couldn't play my Nintendo Switch." I might say something like, "Uh-oh, sounds like we might need to figure out a way to deal with little sister that doesn't get you into trouble, huh? What do you think?" So in that example, I am using information that that this child has recently collected. That, man, when I get into a fight with my little sister, my mom gets upset, and then I can't do something that I want to do. And so really what we're trying to do in this first scenario is focus the child on the more immediate moment and the immediate consequence of what he did. If I were dealing with a 17-year-old, it might go something like this. "Can you tell me about what happened yesterday when you got into an argument with your little sister?" And let's say the patient said, "Yeah, my mom blamed it on me like she always does." I would use a slightly different approach given the developmental level that the 17-year-old is probably at. And I might say something like this: "Listen, I know that's got to be frustrating, but remember, we've been working on impulse control because of how important it's going to be when you leave for college next year." So that's just an example to show that what we're really working on with the 17-year-old is thinking more long term. So yeah, maybe your mom's not being fair to you, right? Maybe she does always blame it on you when you and your sister get into a fight, but you're really close to being an adult, and there are going to be a lot of situations where you have to restrain emotions that you feel, or maybe you restrain the behavior when you feel this really intense emotion. And let's not make this about your mom. Let's make this about long-term development of you and long-term thinking about how these emotions and responding to them right when you have them might not be very effective for you as you transition into adulthood. That, long-term planning of behavior is not going to work at all for a 7-year-old. And so sometimes what we encounter in clinical practice, in dealing with parents is sometimes I often see parents who are trying to use the same reasoning that they might use with their 17-year-old with their 7-year-old, to say something like, if you lie, you're going to turn into a thief, right? And they're like, do you want to grow up and be in jail? And the 7 year old's like, no, but it doesn't really translate into any long-term behavioral change. And so what you want to focus on really with children who are in these more concrete operational stages are things that are immediately or pretty immediately going to give them some reward or for behavior that you want, or some punishment for behavior that you don't want. So it was a pretty good move by the 7 year old's mother to have the consequence of him not playing his Nintendo Switch after having a fight with his little sister, rather than focusing on how this type of behavior might translate into personality problems when he turns into an adult. In thinking about some of these issues more broadly, there are some other things to consider that I didn't talk too much about in the previous slides. So I just wanted to have about 3 points here at the end to think about some ways that developmental differences or developmental factors might impact clinical work. So one of those would be that information about a child or adolescent's cognitive functioning can impact the nature of therapy. So, for example, I don't know how much y'all remember about crystallized IQ versus fluid IQ, but really crystallized intelligence is referring to information that a child has acquired over time, and is really thought of more as like verbal IQ, whereas fluid intelligence is more about nonverbal processing. And so if I know that a child has some verbal difficulties based on IQ tests or based on academic performance or things like that, I'm probably going to use more behavioral strategies in working with that child, because they might, insight-oriented approaches that rely on higher order verbal processing, they're probably not going to work all that well. Another thing to consider is that understanding normal developmental processes improves diagnostic accuracy and reduces potentially harmful treatments. And what I mean by that is, I can't tell you how many times in clinical practice I've had a parent present to my office with a child who thinks that the child is hearing voices, and then as we talk about the nature of these quote unquote hallucinations, it turns out that the child's not hearing voices at all. The child is really talking about their conscience, or you might call it their own internal dialogue. And so, given the developmental challenges that children encounter, particularly younger children, in explaining the experiences that they have, you certainly wouldn't want to jump to the conclusion that this child is experiencing this rare phenomenon of psychosis and recommend to the parent that the child be placed on psychiatric medication when the child's really having the same developmental difficulty explaining his experience that thousands of other children his age also have, and their idiosyncratic way of explaining it made it sound to the parent like the child was hearing voices or having a psychotic experience. So finally, number 3 here is, if we know that particular variables impact cognitive functioning during critical periods of development, it is possible to intervene therapeutically and mitigate these problems. Of course, this number 3 transitions rather conveniently into our next topic. But what I mean here is that the developmental differences that we're talking about obviously don't occur in a vacuum. So children don't just progress through these stages really nicely, all at the same rates, like it seems like they do when we're reading our textbooks. Sometimes there are lots of environmental factors that impinge on that, and one of the really rewarding things about doing the work that we do is that there are times when we can intervene when we see a child being impacted by something that might affect them long term developmentally. And of course, that can get sticky at times, which is what we're about to talk about. but it can also be very rewarding when you see that you may have been a piece of the puzzle in helping a child avoid something that could negatively affect them developmentally and have an impact on their life for years to come. So, one of the most common ways that this manifests itself is in maltreatment of children. And I listed this as one of the most challenging things for me in dealing with children, just because it's something that seems so senseless at times and preventable, but just has an impact on so many children that we see in clinical practice. So, in thinking about some of the risk factors that go along with children developing psychiatric disorders, they are numerous, of course, like with many other medical problems. For example, genetics certainly plays a role in the development of psychiatric disorders, um, and lots of other factors. But when we look at the overall nature of what seems to place children at risk uh, for developing psychiatric disorders, about 45% of the risk factors involve maltreatment. And so we'll go through that in a little bit more detail and talk about what we mean by that. So there are a lot of different ways to define maltreatment in children, but what we're talking about here is really, in a clinical sense, physical, sexual, or emotional abuse or neglect. And so, given that it's pretty obvious what physical and sexual abuse are, I think it's probably more important that we spend our time unpacking what emotional abuse means. And I like this definition of it that was given by Teicher and Sampson in 2013. Um, and this is just sort of a paraphrasing of their definition, but they define emotional abuse as verbal abuse, manipulation, for example, strategies designed to create shame, guilt, or fear for the benefit of the perpetrator, lots of times, which is the parent, destroying things of value to the child. And I added this example. So that would be like a parent destroying a child's Xbox with a hammer when they got upset with the child, or placing the child in situations that are harmful. For example, it is emotionally abusive to a child to have them in a situation where they are witnessing domestic violence. Um, I guess you could, in some ways, also call that neglect. And neglect kind of falls into two categories as well. So there's physical neglect, which involves the failure to provide for the child's basic physical needs like food, clothing, physical safety, supervision, their physical health. So we're starting to talk about, in a sense here, Maslow's hierarchy of needs, but also emotional neglect, meaning failure to provide for the child's emotional needs. For example, being emotionally unresponsive when the child is distressed, expecting the child to manage unsafe situations or those beyond their maturity level. So, for example, I think about a couple of cases that I've had clinically where, children would be dealing with very difficult family circumstances. Let's say it was a young child, a 7 or 8 year old child, and the parent would be emotionally neglectful in the sense that they didn't fully appreciate the impact that this was having on the child. And sometimes that was because they didn't understand it cognitively, but I think also I've encountered numerous situations at least where I think the parents' own emotional state related to conflict in the family was having a huge impact on their ability to deal with it in the way that it was impacting their child, because they couldn't even deal with what they were experiencing. So childhood, abuse, of course, can be very damaging long term in terms of the child's brain development. But neglect can also be very damaging, and I think it's something that probably gets a little bit less attention than abuse does, at least in the media sometimes. In thinking about how maltreatment affects children, I think most people are probably aware that it affects them psychologically. So it's no news flash when you tell a person, yes, a child who's been maltreated, whether again abused physically, sexually, emotionally, or neglected, that can affect them psychologically. But I think one of the things that is surprising to most people when they hear it is that research shows that abuse and neglect during childhood results or can result in both structural and functional changes in the brain that can last throughout the lifetime. So, as a great example, um, Teicher and Sampson, I've got the reference at the end of this, at the end of the lecture, but they reviewed numerous studies that showed that reductions in the size of the hippocampus were present in adults who endured maltreatment as children. And as you know, the hippocampus is involved in memories and consolidation of memories. And I want to say in this study that they looked at 37, or this paper, they looked at 37 different studies. And in 30 of the studies, children who had been maltreated had significant reductions in the size of their hippocampus compared to children who were not maltreated. And so this is a finding that's consistent across, multiple studies and multiple parts of the brain, not just the hippocampus, but changes in the volume of other brain structures like the amygdala and other areas of the brain. So it's pretty widely known that maltreatment can impact psychological functioning, but I think probably much much less widely known that it actually affects the structure of the brain. Um, and so if we're talking about how that happens, basically, you can think of it like stress from those experiences, from those what they call toxic stress experiences, are thought to trigger changes in the body, like release of stress hormones that influence brain growth and function, which permanently alters the way the brain functions when it occurs during these really critical periods of development. So again, the best way to say it when we're talking about brain development is to say that it doesn't occur in a vacuum, and that kind of connects back to some of these other issues that we were talking about that make clinical work challenging sometimes, are these developmental factors. So while we don't have time to get into it really in this lecture, um, you know, there's plenty of research out there that supports the idea that neglect, for example, educational neglect, has an impact on crystallized intelligence, meaning that children who are not exposed to, um, you know, stimulating activity from an educational standpoint, they tend to have less well developed verbal skills. And so again, I guess the take home message is those developmental factors that we talked about earlier in this lecture don't occur in a vacuum. They are heavily influenced by environmental factors, and sometimes in a therapeutic setting, we have the opportunity to intervene in those situations. So, in considering how maltreatment impacts clinical work, I want to go through these. Maybe give you three things to think about again. So, number one, one way that maltreatment can impact clinical work is reporting it, which we are required to do. Most often, we report it to Child Protective Services, or some other state agency, depending on where you live. It's required by law. So psychologists, like teachers, and various other professionals, are what they call mandated reporters, meaning that if I become aware that a child is being abused or neglected, I have to report that by law. And so that, of course, is an understandable part of the law. It does function to protect children in cases where they're being abused or neglected. but clinically, it can certainly negatively impact rapport both with the patient and with the caregiver, particularly if the caregiver is the abuser. So, for example, if with rapport being of utmost importance in the relationship with a child, suppose early on in the rapport building process, um, you know, abuse or neglect comes to light. Now, when I report it, I don't necessarily have to tell the parents that I'm reporting it. The agency here in Georgia, DFACS, says that they will keep that information confidential, but I always do tell the parents that I'm reporting it because I think it's a therapeutic issue, and I don't think there's any reason to hide that. For better or worse, sometimes that doesn't go over very well. Uh, but I feel like that's a better option than trying to hide it from them or trying to plead uh, ignorance about who reported it. Because a lot of times they know anyway. I mean, if a kid discloses something to me on Tuesday, and I have to report it within 24 hours, and I report it, and a caseworker shows up at their house the next morning, um, it's pretty obvious who reported it. So that can obviously impact rapport with the child. It can affect their level of trust, and that's one of the reasons why it's really important at the outset of treatment to make sure as best you can that both the children and parents understand what your responsibilities are when you go through the informed consent process. So making sure that children understand if they tell me that they've been hurt in any way, or if there's any situation where they have the potential to be hurt, or not, have the things covered that they need to have covered, like their physical needs, that we might have to break confidentiality and talk to somebody about it. And so that helps to I guess tamp down some of those potential problems, but it can certainly always affect rapport. And I have had cases where after I made that kind of a report, parents didn't come back. Um, so it's that can be a really difficult part of clinical practice. Um, but I would say one of the more common things that happens is that the focus of treatment often changes. So there's this when a patient comes in to see you, there's what's called the presenting problem, meaning what was the initial presenting concern when they got to you, and often that is quite different than the problem you end up dealing with. So the presenting problem might be, my child is, having anger outbursts at home. And so, as we do background information in the initial intake session, and we start gathering more and more information as treatment goes on, sometimes it turns out that the child's anger outbursts at home are some of the most benign problems there. But the child has been sort of pathologized as the one that is the problem. When on occasion the child is the least of the problems in the house. And so sometimes what that does is shifts the focus of the work to either family dynamics. Sometimes it might shift it to the individual problems of one of the parents or of both of the parents or other family members. So, for example, I put down here a parent's substance abuse as an example because that's one of the most common issues that I deal with. So sometimes parents come in and uh, you know, have, again, as the presenting problem, this is going on with my child, and on multiple occasions over the years, there's turned out to be a parent who is abusing substances, and that's having a huge impact on family dynamics and arguments within the home and things like that, and even sometimes neglect. And so sometimes when a child is being maltreated, the focus of the treatment changes, and and it takes quite a bit of experience and sometimes even consulting with other professionals to decide how to handle those situations. And finally, an issue that I think is pretty relevant to me, and again, one of the reasons that I chose this is that being around children and interacting with children on a regular basis who have been abused or neglected increases the stress level of the provider, meaning the psychologist or the person who's treating the child, which can trigger burnout. And so it's not. I'm not trying to make this all about the clinician at all, but the reality of it is that mental health professionals do have much higher rates of mental health problems, uh, and than many other professions. In fact, there's this idea in the literature now that a friend of mine actually researches and studies called vicarious trauma, meaning that you can start to experience burnout from hearing about the traumatic experiences of others. And so that's definitely a factor. Also, for me, just to be honest, countertransference toward the parent. And what I mean by countertransference, in case you've forgotten it or not really exactly sure what it means, is having a strong emotional reaction toward a parent who's not treating their child very well. And so that is something that I think uh, you have to deal with on a regular basis. That can be stressful, particularly when the parent is either unmotivated, lacks insight, or or is outright hostile toward your suggestion that their behavior is abusive or neglectful toward their child. And so when I've talked about this before, people have said things like, well, when you notify DFACS, the Department of Family and Children's Services, they don't do anything. Yeah, sometimes they do. Um, but the ways that DFACS can intervene, uh, it ranges very, very widely in a parent losing custody of a child to literally doing what they call screen out, which is going, yeah, that doesn't really meet our criteria, and doing very little investigation beyond that. So sometimes there are things that, of course, rise to the level of concern for me as a clinician, that I feel like need to be reported, and so I do my duty to report that. But it certainly doesn't mean that uh, that DFACS intervenes or another agency intervenes and that the problem is fixed. These agencies are often, uh, you know, understaffed. All sorts of problems are thrown at them, and really the more intensive interventions are only done in cases where a child is in an extreme circumstances, which leave is in an extreme circumstance, which leaves a whole huge swath of problems out there that just kind of continue to float around to clinicians like me and other people who deal with it. So now we transition into the final part of the lecture here, medical interventions for children and adolescents. And this is always a really difficult issue for people to talk about because people have really strong opinions on it. I, of course, have some strong opinions on it, and you'll hear some of them here today. But there's I would say some controversy about using medications in the management of psychiatric problems with children and adolescents. But there's also a huge literature that shows that the vast majority of the time these medications are very, very effective, and the side effects that go along with them are very manageable. So we'll talk about a little bit of that today. But first of all, just in thinking about um, when children and adolescents are placed on psychotropic medications, um, to clarify a little bit about that, I just wanted to make sure that everybody knew that, in general, this happens when it's deemed medically appropriate by a medical doctor in consultation with the family. And like I said, and often with other mental health professionals. So what I mean by that is, psychologists do not prescribe medications. Most of the time, there are a couple of states in the United States where psychologists under certain circumstances, are allowed to prescribe psychotropic medications. But the vast majority of the time, the people who are prescribing psychotropic medications to children are either their pediatrician or a child and adolescent psychiatrist. And so medications are prescribed when a medical doctor deems it appropriate in consultation with the family, given the severity of the child's problem. And so there are other, kind of mitigating circumstances in terms of why a medication would be prescribed to a child. So sometimes they're prescribed when other treatment options have failed. So, for example, sometimes parents come to my office and they are opposed to their child being on a medication and they want to try therapy first. And generally, I'm open to doing that, just depending on what the circumstances are. But then after several months, if let's say the therapy's not working to help, you know, get control over the anxiety or depression symptoms, or whatever other symptoms they have. And certainly, if the condition's getting worse, then sometimes we consider, consulting with the child's pediatrician or with the child and adolescent psychiatrist about medication options in addition to therapy. Also, one thing we're always looking at is when the potential benefits of medication outweigh the risk, meaning exactly what it sounds like is we're kind of looking at both things, and we'll talk about that a little bit more here in a second. But we're looking at, of course, any medication that you take has risk. Even Tylenol and a lot of over-the-counter medications that you purchase have risk, but the benefits of that should outweigh the risk if you decide to treat yourself or of course in this case we're talking about treating children with psychiatric medications, and so that's something that has to be determined by the child's family in consultation with a medical doctor, because people have different values and different belief systems as it relates to that, and so we always want to be sensitive to it. So the most common diagnoses that are seen in my office that require medical intervention would be ADHD. So, there's the combined type of that. There's the predominantly hyperactive impulsive type, and then the predominantly inattentive type. Most of the time, when a child has the predominantly hyperactive type or the combined type, the medication they would be placed on would be an amphetamine, which would, sometimes they're referred to as stimulants, which actually, for children who are hyperactive, tends to significantly calm hyperactivity. Other disorders that I see pretty often: obsessive compulsive disorder, anxiety disorders like panic disorder or generalized anxiety disorder, post-traumatic stress disorder, major depression, intermittent explosive disorder, conduct disorder, some bipolar disorder, but I don't see a whole lot of pediatric bipolar disorder in my office, but I have had a few of those cases. But these are the most common ones seen in my office that require medical intervention. So, what of the controversy about medical intervention in children? Well, there are numerous different, I don't know if you would call them controversies, but numerous things that have been out in the press about psychiatric medications in children. I know there was a Netflix special, at least one, about it. And so we'll only focus really on one of those today, but there are all sorts of reports in the media about controversies or potential dangers of psychiatric medication use in children. And there's some literature that supports certain types of medication having some negative long-term effects for children, and so you have to weigh that again with the benefit. So I wanted to just really focus on one today, but like I said, there are a whole bunch of them. But I think this is probably the most common one, and one that I think still seems to echo through the years, because I still hear people talking about it, and it's something that I address probably on at least a weekly basis with parents, and that is the 2004 FDA black box warning for uh, antidepressant use in adolescents. So there's a quote here by a physician who I think wrote this for the New England Journal of Medicine. I can't remember exactly now without looking at the references, but this just gives you kind of a synopsis of it. So he says the agency, he's talking about the FDA, had conducted a series of meta-analyses of 372 randomized clinical trials of antidepressants involving nearly 100,000 participants, which showed that the rate of suicidal thinking or suicidal behavior was 4% among patients assigned to receive an antidepressant, as compared with 2% among those assigned to receive placebo, although none of the suicide attempts documented in the trials were fatal. Okay, so basically what happened was the FDA in 2004 looked at a very large sample of adolescents who had been prescribed psychiatric medications, and when compared to the placebo group, who was not getting the actual treatment or the actual SSRI, the rate of suicidal thinking or suicidal behavior was twice that of the placebo group. Okay, so the placebo group was essentially one person in 50 who took the placebo either engaged in more suicidal behavior or had increased suicidal thoughts. And in the group who actually took the antidepressant, it was 2 in 50. So given that in the experimental group, suicidal thoughts and suicidal behavior was twice as high, the FDA issued a warning, which they essentially had no choice but to do that, because they certainly didn't want to hide that information, to explain to physicians that they needed to talk to parents about this and make sure that they understood, and that the teenagers understood that there could be some increased suicidal thoughts with antidepressant medication, like had been shown in these 100,000 participants that they looked at. The problem came in where in the year, and I want to say in numerous years after that, prescriptions for antidepressants for adolescents decreased dramatically due to fears from physicians and parents and the adolescents themselves about the possibility of increased suicidal thoughts or possibly increased suicidal behavior if they took the medication. And there's some controversy about, I've said controversy about 50 times today, but there's some debate, I guess is the best way to say it, about what actually triggered an increase in suicides among adolescents in the years following the FDA black box warning. Some people say, some researchers say it had nothing to do with it. Some say that, okay, well, you look, the prescription rates of antidepressants go down, and the suicide rates of adolescents go up pretty much proportionally in the years that followed. So I'm not sure if it was because of that or because of more data. In 2007, the FDA released another statement to kind of clarify it and said, look, depression itself is associated with an increased risk of suicide. Okay, so you can't just look at the black box warning and sort of throw the whole idea out the window. you have to look at the overall picture. And so this is a really difficult conversation that I have with parents and that I have with teenagers, um, which is that, you know, in looking at the overall data, number one, you're talking about 100,000 participants on either the medication or the placebo, zero of which actually committed suicide. Number two, even in the group who took the SSRI or the antidepressant medication, 96% of the time there was no increase in suicidal thoughts. There are also research studies out there that show that antidepressant medications decrease suicidal thoughts. So, and also if you consider that 2% of those taking a placebo had increased suicidal thoughts, you could actually say that probably the actual percentage of increased suicidal thoughts that occurred on the medication was about 2%, because you factor out the other 2% placebo effect. So maybe 1 out of 50, or maybe 1 out of 50 adolescents who took the antidepressant medication did have increased suicidal thoughts, but even in those cases, or suicidal behavior, but even in those cases, there were no successful suicide attempts. So again, this is one of those areas where policy decisions and clinical practice kind of crash into each other head on, and there's still a lot of debate about whether the FDA's black box warning did more harm than good, and what not only the FDA says about medications, but what is released in the media about various medications for children and adolescents, and whether that really has a negative impact on prescription rates and on perception of medication in general. So I know that was somewhat of an extended explanation of that, but it's really frustrating for me uh, at times, because we have these external factors that are influencing parents and teenagers and physicians about the potential dangers of taking antidepressant medication, which again, I'm conflicted on the warning being put out there. I think people needed to know, but on the other hand, it's looking at, okay, what has been the long-term ripple effect of this black box warning, and in the public's mind, it's sort of tainted the idea that children can be effectively treated with antidepressant medication, when the overall evidence is, in my opinion, very clear that it is generally both effective and safe. That, of course, doesn't mean that it is in every single case, but you can't say that about any medication or any medical treatment on earth, because that would be a really unrealistic thing for us to expect. So, again, we're going to finish up with these with kind of 3 points about how medical interventions impact clinical work. Number one, uh, in most cases, psychotherapy is done in consultation with the prescribing physician, and the physician is routinely updated on patient progress. So I talk to medical professionals every week that prescribe medications to patients that I see. We update each other on progress, and a lot of times it's me giving them more information than they're giving me, because um, I'm spending a lot more time with the patient than they are, and so they rely on that to get a little bit more insight about, if the medication needs to be changed, if there are environmental factors, like we talked about earlier, that are playing a role, that changing the medication wouldn't really do any good, or wouldn't be likely to do any good. So number one, medical intervention impacts my clinical work, because it really gets the interdisciplinary work going with another branch of treatment that can actually be really helpful in most cases. Uh, Number two, there are virtually no psychiatric disorders where medical intervention alone is recommended with no indication for therapy. And I'm saying that in the context of children and adolescents, but I'm not really even sure if there are any, psychiatric disorders among adults uh, that you could identify that said yes, only medication is recommended. I think probably at least any psychiatric disorder that I can think of, the person could also benefit from therapy, not just from medication. So, um, you know, psychiatrists and other mental health professionals are going to be working a lot, right alongside counselors and psychologists and social workers. And so we are, our work overlaps a lot. And so certainly, we're going to be seeing patients that are taking psychiatric medications, and we need to be educated about them, and educated about safety and the effects of the medication, and side effects that they can expect, and when to be concerned, because there is a time for that. But I think my experience is that I usually feel like I'm paddling upstream in talking to parents who are concerned about the medication impacting their child in ways that are not likely to happen. And so finally, if the symptoms are severe enough, medical intervention serves to make the interventions in my office much more effective. So, for example, uh, this is one way that I think medical intervention significantly improves what can be done in therapy. One example that I'm giving here is severe hyperactivity and inattention, ADHD. So there are certain behavioral treatments that can be quite effective for kids with ADHD, but the only way that you can teach that to a kid with ADHD is to get them to sit down long enough and pay attention long enough to listen to what you're saying. And that usually starts with stimulant medication. um, to sort of wrap things up with an Augusta tie-in uh, for Taryn, or Dr. Myers as y'all call her. She might remember this or she might not. Uh, I had a patient who we talked about in clinical supervision once when I was in Augusta, who was so hyperactive. Um, as I was starting the session with him, I literally had to ask him not to stand on his head, um, so that we could talk. And so when you have children who are so hyperactive that you have to instruct them not to stand on their head, which takes about 10 to 15 minutes of your time, when you're telling them not to do that, and then not to do the next thing that they're about to do, before you can even get to the content of the session, medication can be very helpful uh, with those kinds of situations. It can also be very helpful when a person is extremely depressed, and they don't even have the energy or the focus or the cognitive functioning to engage in the cognitive restructuring strategies that go along with psychotherapy. Um, and so medication often helps not just make my job easier, make it possible. And so that's why I'm a really big proponent of it in most cases when it's clinically necessary. Um, and
you might wonder, well, then why did you list it as one of the big frustrations? The frustration is not necessarily the medical intervention itself, but the hoops that often have to be jumped through to convince the patient that it's most likely going to be safe, uh, or in the case of children and adolescents, to convince their parents that it's going to most likely be safe for them, because there's a whole lot of misinformation, or as some people call it, fake news, about um, about medications and their impact on children. And that is the uphill battle, or the upstream battle, that I'm often fighting, along with many other people out there. But you know, like them, I believe it's the right fight to fight. Um, if that's southern enough for you, the right fight to fight. Uh, and That, along with some of these other issues that I believe we also need to fight, like you know, more support for families where children are being maltreated, and also making sure that um, we're all, you know, doing what we need to do from a prevention standpoint to protect from exacerbating developmental factors that are already difficult enough to deal with um, by themselves and with no complicating factors. Um, Thank y'all for being attentive. I hope I didn't bore you too much, and I hope that you don't need a translator for my accent.